Good afternoon, everybody, and welcome to the SBIRT Collaborative Implementation Webinar on Addiction and Dependence Treatment. I am Amy Etzel, Implementation Manager with the SBIRT Collaborative. I'd also really like to take a moment to just thank you all for being here during this very, very busy time. I know that taking an hour out of your day is not easy in these uncertain times that we're living through, so we really appreciate your time in joining us today. Before we begin, just a few quick announcements. NQAC will accept attendance at this webinar session as a CE event. To receive credit, you just need to document your time and submit a short survey. You'll receive an email later today or tomorrow with a link to this survey along with today's presentation slides and resources. Please remember that if you want a certificate for a credit hour, you must provide either your license number or an equivalent ID number and complete the survey by next Friday, May 8th. If you have any questions about this, please contact NQAC directly. You are all currently on mute and will be throughout this webinar until after our presentations are done. Today's speakers and I would love your participation in a Q&A discussion at the end. If you have any comments or questions, please type them into your chat box and I will use them to facilitate the Q&A session at the end. Today's speakers declare no affiliation with or financial interest in a commercial organization that could pose a conflict of interest with the educational content of this program. Okay, that ends our housekeeping portion of the day. Now for a quick background on the SBIRT Collaborative itself and our guideline development process. We are a public-private group in Washington State formed by our state legislature in 2011. Our goal is to improve healthcare quality and outcomes and affordability throughout Washington State. Our collaborative members are made up of healthcare leaders around the state, and they represent healthcare plans, healthcare purchasers, both private and public, including our state Medicaid agency, and private purchasers, as well as representatives from various delivery systems across the state and other quality improvement organizations. So every year, we select 4 to 5 healthcare topics or services that have variation in delivery or outcomes, that are used inappropriately or too often, or that maybe are not used enough, that have a patient safety issue or maybe an equity issue that our community cannot address alone or in any other way. So our recommendations are formed by clinical committees or work groups made up of community members with expertise in that selected topic. And then this collection of volunteers meets for about 9 to 12 months. And then they have this work group where they review published literature, guidelines from specialty societies, the work of other quality improvement organizations, national entities, and then programs and policies within our own local delivery systems. So as you can see, we've worked on a wide variety of topics, starting with obstetrics, looking at appropriate C-sections, and we've also developed best practices for topics such as low back pain and end-of-life care. So our addiction and dependence treatment report and recommendation was adopted in 2015 by our community, and each of our guidelines is usually framed around a specific focus area. Our addiction and dependence report identified 5 focus areas to frame our recommendations around. So as part of the SBIRT's implementation efforts, I've been developing some starting ground implementation resources. These will be emailed out later with our slides to you. And the first is here on your screen. It's an implementation checklist for clinic staff outlining these 5 focus areas and the various action items that clinics can take toward implementation of our recommendations. Obviously, our clinical partners are going to get into the details of each of these later on and how they are implemented on the ground, but I also just wanted to discuss them briefly here and highlight a few of these actionable items. And I also want to say that we fully recognize that not all of these steps can be taken right away and they're going to take time and money to be fully implemented. You all face such a wide variety of limitations within your clinics and within our overall healthcare system around staff and budgets and time and reimbursements, et cetera, et cetera. What we've laid out here is really meant to be a pathway to full implementation. And in my mind, any progress down that path is really, truly success. So the first focus area is about reducing stigma around substance use disorder. This is really about educating your staff on current trends, what's happening out there in the community, as well as empathy and sensitivity training regarding substance abuse. And we really mean all staff here, not just provider staff. Maybe educating the front desk staff on stigma and sensitive language could help the patient's overall comfort level, which then leads to better engagement with their provider. Maybe educating the management teams on the connections between alcohol and drug misuse and their overall health can help sway budget priorities toward dedicated staff for this area, that kind of thing. We also really emphasize almost normalizing the topics of alcohol and drug misuse in routine care, helping patients understand, and then showing that you as staff understand that this is a disease that can be treated like any other disease. And that can really go a long way in helping to engage your patients more and encourage them to seek and maintain treatment. So the second and third focus areas are really about increasing screening and then increased capacity for brief intervention and treatment. This SBIRT model is really the bulk of the content of today's webinar, and our clinical partners will get into how they're using it within their settings. So I'll save most of the time for our experts, who obviously can talk about this area better than I can, but I do want to call it a few key elements. So our BRE report recommends screening with the use of a scaled and validated tool of all new patients over the age of 13, and then implementing universal screening annually in a primary care, prenatal, and ED setting. This, along with our recommendation of increased capacity for brief intervention and treatment, is one of the recommendations that can be hard to implement due to system restrictions of time, budget, staff, etc. And that is okay. Any movement toward that end goal of full implementation is great. And there are a variety of ways to work SBIRT into your workflows that our partners are going to talk about in just a little bit. I also wanted to call out the importance of having really clear processes in place that all staff are familiar with regarding triaging and referring out as needed to treatment facilities, and then also establishing a tracking process and having designated staff to follow up with patients who've been referred out. This leads into our fourth focus area, which is about decreasing barriers for referrals to treatment facilities. This can be especially difficult for smaller communities who may not have a lot of treatment facility options within their area, where patients may have to be traveling fairly far, or, and this is true for all areas, not just rural, where there are long wait times and other access issues that make it hard to complete that referral. This is, again, where we emphasize a strong and clear follow-up and tracking process to keep up with the patients that have been referred. We really encourage a facilitated and supported referral, meaning verbal confirmation from both the facility and the patient. That support piece to the patient is really so important, really having designated staff, if your budget allows, to help a patient navigate any barriers like cost or transportation. It's just so important. And even just like the seemingly simple act of keeping that communication open and letting them know that you're still thinking about them and can really go a long way with patients in encouraging them to keep that referral and maintain treatment once they're engaged. And then our fifth focus area focuses on the opioid epidemic. And I'm again going to save time on this one and just put in a plug for our May webinar, which is happening on May 27th, which will focus on our opioid use disorder treatment report published in 2017. So I've also identified, as part of my implementation work, some basic core process measures for clinics to focus on, particularly for clinics that are in the beginning stages of prioritizing addiction and dependence treatment for their patient population. Another aspect of my implementation work is to do some targeted practice transformation around behavioral health integration into primary care with some clinics around the state. And so these are some measures that the clinics I'm working with who have prioritized addiction and dependence have been using to focus in on moving toward that full implementation. Okay, now I'm going to turn it over to the true stars of today, our speakers. First up, we have partners from King County who will be talking about the use of SBIRT in the emergency department setting. Jennifer Wyatt is the SBIRT coordinator with King County Department of Community and Human Services, Behavioral Health and Recovery Division. She has extensive clinical experience utilizing evidence-based practices with adolescents and adults in outpatient, residential, and secure settings, and has been a member of the Motivational Interviewing Network of Trainers since 2012. Amy Decker is currently the social worker supervisor for 3 hospital emergency departments in King County and supervises the clinical practice of social workers, counselors, and substance use disorder professionals. She's been a licensed independent clinical social worker since 2004. And then Sunny Levin is a licensed independent clinical social worker who serves as the senior clinic manager for Harborview Medical Center's outpatient behavioral health department. She started supervising the supported employment, supportive housing, and peer support services programs in 2008 and moved into a clinic program manager role in 2012, which allowed her to oversee several programs, including SBIRT. All right, ladies, take it away.
Thank you, Amy. Would you advance to the next slide, please?
Sure.
Thank you. By the end of this webinar, attendees will be able to describe the history and mid-funding of emergency department SBIRT services in King County, explain the three parts of SBIRT, which are screening, brief intervention, and referral to treatment, describe two workflows for SBIRT implementation in emergency departments, identify two challenges and two benefits of implementing SBIRT in emergency departments, and connect emergency department SBIRT implementation to the BRE Collaborative's 5 focus areas in their addiction and dependence treatment report and recommendations. Next slide, please.
All right.
So let's start with how emergency department SBIRT services were established in King County and how they are funded currently. In 2003, Washington State was awarded a statewide grant from SAMHSA titled WASBIRT. Over 5 years, the grant funded implementation of SBIRT in 9 emergency departments throughout the state. Following completion of this grant in 2008, King County continued funding emergency department SBIRT services using MID, which is a local sales tax supporting about 50 behavioral health and recovery initiatives. To date, SBIRT services are delivered in 3 King County emergency departments: Harborview Medical Center in Seattle, St. Francis Hospital in Federal Way, and Highline Medical Center in Burien. Next slide, please. The SBIRT clinical teams consist of an implementation lead and 1 or more clinicians. The implementation lead is responsible for oversight and administration of the program, including hiring qualified staff members and ensuring accurate data collection. The SBIRT clinicians may have a variety of behavioral health credentials. They may be substance use disorder professionals, social workers, or licensed mental health counselors, for example. Each staff member has been trained in foundational motivational interviewing skills, as well as in delivering SBIRT in the emergency department setting. Most importantly, SBIRT clinicians are part of the medical team working together to provide whole person care for patients. Next slide, please. SAMHSA defines screening, brief intervention, and referral to treatment as a comprehensive integrated public health approach to the delivery of early intervention and treatment services for persons with substance use disorders, as well as those who are at risk of developing these disorders. Primary care centers and emergency departments, for example, provide opportunities for early intervention before more severe consequences occur. I'll briefly present the SBIRT structure before turning it over to Sunny and Amy, who will share their specific hospital workflows, as it's different in different settings. In the King County implementation, in the King County implementation, the first step involves administering a 5-item validated screen called the AUDIT-C+2. Using evidence-based screening tools is part of the BRE Collaborative's Focus Area 2 recommendation. The screen identifies risky use of alcohol, cannabis, and other drugs, and feedback is shared with the individual immediately. Amy, would you go back 1 slide? Thank you. That's okay, it's all right. Next, so after the screening is completed with a validated screening tool, the clinician delivers a brief intervention using motivational interviewing skills and strategies to understand the person's substance use and enhance their motivation for change along a continuum that might range from harm reduction to sobriety and includes all the places in between. Finally, if referral to treatment is indicated, the SBIRT clinician connects the patient to a range of behavioral health treatment options based on their needs, goals, and values. So now I'd like to turn it over to Sunny, who will discuss the Harborview SBIRT workflow.
Thanks, Jennifer. So at Harborview, historically, the King County MID contract that helped us launch SBIRT pays specifically for FTE, and we recognized pretty quickly that 3 to 4 FTE are not really going to promote universal screening in an ED setting on a 24/7 basis. So what we did is we partnered with our ED social work team, and we incorporated the SBIRT screening, the AUDIT-C+2, into the social work intake at the ED. So roughly 65% of patients that are admitted to our ED are seen by social work, which really helped boost our numbers and our ability to provide a true universal screening. And it also helped to ensure that service is provided on a 24/7 basis. Anyone in the ED can refer a patient to the social work department. So even if social work isn't triggered to see that patient, they can still be referred if it's simply just for the SBIRT screening. Social workers conduct the initial screening and provide a brief intervention utilizing MI techniques. Patients are not always ready to discuss their use, and so if that's the case, the service may end there. Other patients who are open to talking with the social worker about their use and how it may be impacting their lives can be offered a referral. One of our SBIRT staff, Jessica Warmbow, has talked about this in her experience and talks about these teachable moments that you often can have with patients in an ED setting. Oftentimes people, this might be their second, third, or more admission to the ED, and each situation may have had some kind of alcohol-related, any substance. She gives an example of a patient who maybe fell off a ladder and broke their leg. And then you come to find out after digging through the chart that this is their fourth admission to the ED, and social worker realizes that there was some substance involved. So it just offers the opportunity to talk with that patient from a very non-judgmental perspective about, what's been going on and how we might support them in addressing that substance use that may be related to these admissions. So it looks very different for every patient, and I think that's where the training comes into play. We've also implemented some services within Harborview that have sparked from SBIRT and from just addressing the need to look at substance use in a different way. We have our outpatient-based opioid treatment program, also known as OBOT. We have that strategically located within our ED aftercare clinic. So patients who may be inducted on buprenorphine, for example, in the ED can then have a follow-up appointment scheduled in that aftercare clinic, as well as primary care outpatient behavioral clinics to promote better continuity of care. The key is really just to offer something that the patient is interested in pursuing at that time and essentially meeting them where they're at. So then I'll turn it over to Amy to talk about CHI Franciscan's process.
Thank you, Sunny. CHI Franciscan, St. Francis Hospital, and Highline Medical Center have similar workflows from the patient's emergency department arrival to meeting with the SBIRT clinician. Whether the patient walks in or arrives by ambulance, the first staff contact the patient has is with a nurse. The nurse asks brief yes or no questions about alcohol, illicit drug use, and tobacco use. Depending on the patient's answers and the chief complaint that brought them to the hospital, the patient may or may not be referred to the SBIRT clinician for a validated SBIRT screening. This pre-screening of patients has been a challenge for our program, and I will discuss this challenge in more detail on a future slide. If the patient is referred to an SBIRT clinician, the first step is the screening. The patient will be screened by a substance use disorder professional or master's level mental health counselor or social worker. The screening consists of the 5-question Audit C+2, which is incredibly easy to use and score. The SBIRT clinician would administer the questions verbally within the flow of the clinical interview, and the Audit C+2 can be immediately scored and the results shared directly with the patient. After sharing the results of the Audit C+2 and determining that the patient has an elevated risk level, the SBIRT clinician begins the brief intervention phase. While continuing to build rapport with the patient, the brief intervention aims to gain a better understanding of the patient's current and past alcohol and drug use, psychosocial stressors, current or past treatment providers, and the patient's current readiness for change. During the brief intervention, the clinician is relying on motivational interviewing techniques to provide feedback and recovery education in a way that empowers patients and focuses on positive next steps. On average, the screening and brief intervention can be completed in about 10 to 20 minutes. The next step, if indicated, is making referrals to treatment. Based on the information gathered during the brief intervention, the SBIRT clinician would make recommendations for treatment. CHI Franciscan relies on community partners to connect our patients with resources and treatment. Our SBIRT clinicians have built solid referral pathways with a variety of treatment providers, including withdrawal management facilities, sober housing programs, faith-based programs, outpatient clinics, and inpatient programs. Our clinicians stay well informed on each program's referral criteria and have up-to-date knowledge of which treatment programs accept Medicaid, Medicare, and other private insurance plans. CHI Franciscan has been able to create partnerships with community treatment providers as a way to expedite referrals from the emergency department to ongoing substance use treatment. Specifically, we have worked with a community behavioral health agency to have 3 designated withdrawal management beds available to directly transfer patients from the ED. We are also working on a referral process between the ED to a low-barrier Suboxone clinic operated by public health. We have found that patients are more successful in their recovery if they have the direct linkage between the ED and the treatment program. It is our ultimate goal that patients leave the ED with specific treatment options and good follow-up plans. We also look for how our referrals to treatment will directly reduce future ED visits or prevent an unnecessary medical admission. Now I'd like to turn it back to Jennifer.
Next slide, please. Thank you, Sunny and Amy. So next I'll share the evaluation plan that we have for emergency department SBIRT services and the data that we collect. So the emergency department SBIRT is one of over 50 initiatives that's funded by the MID behavioral health sales tax. Evaluation occurs in a results-based accountability framework, which essentially looks to ascertain how much did we do, how well did we do it, and is anyone better off? So I'll share the 2017 and 2018 findings on these 3 performance measures, as 2019 is still in the works. So for how much, we collect progress toward the annual goal of delivering SBIRT services to 2,500 unduplicated people. Sunny mentioned that sometimes it takes people a few visits to the emergency department before maybe they're ready to consider making changes. And so what we do is we unduplicate people. So we make sure that person counts as one person. So often the services that are provided are much more than just to 2,500 unduplicated people. Quality improvement efforts based on this data resulted in achieving 99% of the target in 2018, which you can see was a significant improvement from 2017. For how well, we look at the number of people who were successfully linked to publicly funded mental health or substance use disorder treatment. Successful linkage is defined as an individual having an authorization plus 1 service in the database that contains billing information. We began collecting this data recently, and for 2018, 22% of people who received an SBIRT service were successfully linked to publicly funded behavioral health treatment. For the last measure, is anyone better off? We compare emergency department admissions of individuals 1 year prior and 3 years after they received an SBIRT service. Our observational data show that in 2018, emergency department admissions were decreased by 40% among clients who received an SBIRT service, thereby reducing the burden on emergency departments. Reductions in emergency department admissions are a finding in the broader SBIRT literature. They're part of the benefits of how SBIRT helps the system. And we're also seeing that improvement in our local implementation sites. So regularly discussing this data as a team guides our performance improvement projects as we continuously work toward improving effectiveness and efficacy. As Amy mentioned in the beginning, it's hard to implement all of these best practices all at once, and we are just making steps toward it, and we're always thinking about the future, trying to do better. Next slide, please. Okay, so I'd like to turn it over to Amy, who will share some implementation challenges.
Thank you, Jennifer. So I'd like to share some challenges that SBIRT clinicians face doing this work. First, universal SBIRT screening has not been possible yet in our emergency departments. We are striving towards that goal. We know that SBIRT clinicians could see more patients. However, patients are frequently pre-screened out, and the SBIRT clinician is not referred by the nurse or the provider to see the patient. Our clinicians have tried to improve this and get closer to universal screening by advocating to see more patients through case finding, watching the ED track board, and talking with nurses and providers about patients who they believe their SBIRT screening and intervention would be beneficial. Also, over the last year, we have expanded from 2 substance use disorder professionals, 1 at each ED, conducting all the screenings in the year. To the entire ED social work team being a part of the SBIRT process. We are committed to moving towards universal screening and recognize that it is a gradual process to reach that goal. The second challenge is related to when there is a discrepancy between a patient's treatment expectations and the resource availability. Patients may have an expectation of what the ED outcome will be. A patient may say, I just need to get into detox. And it becomes a balancing act between what the patient is requesting, the patient's clinical presentation, bed availability, and patient's insurance, along with maintaining the brevity of an SBIRT and being mindful of the ED length of stay. Our clinicians have been able to navigate, a patient's frustrations and work with them on a different path through recovery. The third challenge we see is patient's insurance can be a challenge to successful referral to treatment. Some payers need pre-authorizations for detox or inpatient treatment. Some treatment facilities only accept certain insurance plans. Treatment is very limited for state-funded insurance programs such as Medicaid and may require the patient to seek out a required assessment at an outside approved agency prior to arranging a bed date for an inpatient treatment program. The disparity in access to treatment is closely related to what type of insurance a patient may have. To meet this challenge, the SBIRT clinicians provide the patient with the best treatment options available. The final challenge that we see in the emergency department is patient volumes may demand that we expedite a discharge prior to an SBIRT screening. We are aware of the pressures of ED length of stay and moving patients through the ED, especially when volumes are high. Sometimes an SBIRT screening could be seen as necessary and needed when patient volumes are low, but not seen as critical when the ED has long wait times and there's the increased need to discharge patients. If an SBIRT patient is medically stable and ready for discharge, a referral to an SBIRT clinician might not be made in order to expedite the discharge. So now I'd like to turn over to Sunny to talk about the benefits.
Thanks. So I think similar to some of the challenges, some of the challenges have also acted in a way as a benefit. Obviously, just initially fewer admissions, reducing burden on emergency departments is a pretty obvious benefit. I think when I've thought about this, since implementing SBIRT, we've noticed that it sparked an interest in more education about substance use across our system for providers and staff, which helps reduce stigma that's associated with substance use disorders. Specifically, our clinical education department here at Harborview, in partnership with our SUD team, developed the first SUD core training, which is training that's offered to any and all UW medicine staff. We're going on our third year of offering that training, and it's been incredibly well attended and received to help support staff. I think many people just have a lot of misinformation or misnomers about patients that are admitted with SUD related issues, and this has really helped to break down some of that stigma and to also empower them to feel like they have better knowledge and understanding of what's available to support patients in those situations. King County has also partnered with us in the past to host several trainings that help clinicians become certified in SBIRT delivery, which is actually a pretty simple process, which then just expands on the number of people who are able to offer that through our system. As well as really sparking more interest in motivational interviewing training, which is a great way to approach patients with these needs. At Harborview, again, specifically, what we ended up doing is creating a strategic oversight committee to look at addictions specifically. From this committee, we've been able to, like I said, provide oversight as well as develop new services to respond to substance use disorder related admissions. So this is where our outpatient-based opioid treatment program has sparked. This is a hub and spoke model that is based in our adult medicine primary care clinic and then has services offered in our outpatient behavioral health clinic, community providers like Country Doctor, our ED aftercare clinic, and it just really gets that harm reduction focused intervention out there and available, very low barrier availability to patients needing it. There's also been a grant that's been offered to our ED that supports buprenorphine induction in the ED, as well as the creation of an addiction medicine consult service that works in partnership with our psychiatric consult service, as well as our pain service at HMC. And then we've implemented a harm reduction based brief therapy as one of our evidence-based practices offered in our outpatient program. So many of these programs have been directly developed in response to, I think, some of the things that SBIRT has brought to light when we start really looking at the data and the number of people that are affected by substance use disorders. The only other thing I think I would mention as a benefit, you know, when people are trying to pitch this sort of a service to higher level administrators or hospital leadership, you know, there really is some cost benefit associated with this type of intervention. You're potentially reducing your ED visits as well as reducing length of stay for inpatient visits. We've looked pretty closely at our data, and most patients who are admitted to our inpatient service with a comorbid substance use disorder have on average a 1 to 2 days longer length of stay than those who are not. So that has a pretty big impact on our bottom line. Staff have benefited from better understanding of substance use disorders and knowledge about best practices to treat patients, which then I think also helps promote the staff satisfaction. And then most importantly, it has helped promote the health and well-being of our entire patient population, which is really the end result. I'm back to Jennifer now.
Thank you, Sunny. Next slide, please. So I'd like to share a little bit about our mechanisms and current area of focus for ongoing performance improvement. So we're always looking at our data and trying to figure out how we can make our services more efficient and more effective for the patients that we serve. So in 2019, we established a learning collaborative where all of the ED providers meet quarterly as a team to integrate advances in SBIRT knowledge. Projects that we've been working on include simplifying the screening process and addressing opioid use, as you've heard both Sunny and Amy talk about. And in 2020, our focus is on developing the clinicians' motivational interviewing skills in a way that's very specific to emergency department SBIRT. Moving forward, we're establishing warm handoffs and service coordination to increase our rate of successful linkage of treatment. And so I'd like to turn this over to Amy.
So the BRE Collaborative focus area number 1 is about collectively working to reduce the stigma towards associated behavioral health disorders. In our organization, the SBIRT clinicians have worked diligently to reduce patient stigma by sharing with their healthcare colleagues their knowledge and understanding of the patient's uneven path to recovery. Because the SBIRT clinicians are viewed as part of the ED treatment team, their clinical opinions and recommendations are highly regarded by the nurses and providers. SBIRT clinicians are regularly attending educational opportunities to have the most current treatment and assessment information. They frequently share this information with the team through individual staff consultations and staff meetings. They have provided focused trainings to nursing units and community groups. And within the last year, our 2 substance use disorder professionals worked individually with their social work colleagues to educate and train them to the SBIRT screening and best practices. Under number 4, and aligned with the focus area number 5, CHI Franciscan is also invested in making connections with clinics that provide medication for opioid use disorder as a way to address the opioid epidemic. Recently, we connected with Public Health Clinic near Highline Medical Center to create a referral process for patients to be connected with Suboxone treatment immediately following their ED visit. We are in the beginning stages of developing a pilot project, which would start by providing a warm handoff to the clinic's intake nurse. The SBIRT clinician would then ensure the patient had the ability to arrive at the clinic shortly after their ED discharge. We are still in discussions with our ED medical provider group to finalize the induction process. We are hopeful that this project would be replicated at St. Francis Hospital in the future. So now I'd like to turn it over to Sunny.
Thanks. And so I think probably reiterating what I had said earlier, You know, again, just reducing stigma, increasing training and support for staff who are providing frontline services to patients who are experiencing substance use disorder has been really key in helping us move forward and promote this service. The creation of our outpatient-based opioid treatment service, as well as the ability to induct patients in an ED setting, has really helped to address that opioid epidemic crisis. As well as with the Healthier Here initiatives that are being launched statewide, as we as a system, a healthcare system, move into more of a risk stratification model, it's becoming more and more important for all of us to be thinking about ED utilization rates, length of stay, readmission rates, all of those things that ultimately will affect our funding streams and systems. So addressing substance use as a comorbid issue related to many of our patient admissions is just key in helping to affect all of those other pieces. And I'm sorry, I'm not sure who I'm turning it over to.
Oh, I think I'll take it. This is Jennifer. Next slide, please. Okay, so I know that we're going to hold questions until the end, till after you get to hear Lisa's presentation. And we hope this has been helpful, and we invite you to contact us if you would like to talk further about anything that we've shared. So thank you very much for your attention, and I'm going to turn it back to Amy Etzel.
Great. Thank you all so much. Such great and important work that you're all doing. And just as an FYI for people that would like to contact the 3 people you just heard from, these slides will be sent out, so you'll have these email addresses available to you. So now we're going to turn it over to our partner, Lisa. She's the Vice President of Medical Services for Planned Parenthood of the Great Northwest and the Hawaiian Islands. They have incorporated screening, brief intervention, and referral for treatment for substance use disorders into their preventive care services, initially as a pilot in 5 of their health centers and now throughout health centers in Washington. They plan to continue to expand SBIRT to all health centers in their 6-state alliance. Okay, Lisa, go for it. Thank you.
Thanks, Amy. Why don't you go ahead and go on to the next slide?
There we go.
So over the next several minutes, I'm hoping to share our reasoning and our model for integrating SBIRT into our reproductive health services and show you some of the really readily available resources that we use. So really, I'm hoping to cover the kind of the who, what, where, why, and when, and how of SBIRT at PPGNHI. My disclaimer is that while we would love to have a behavioral health expert in each of our health centers, this really isn't our reality. And so what I'm going to be talking about is how we've trained and supported our frontline clinicians to begin to integrate screening and brief intervention for behavioral health disorders into our reproductive health services. So go ahead and go on to the next slide. All right, so preventive care at PPGNHI includes taking a comprehensive history and identifying and addressing identified risks and gaps, particularly related to, you know, the common things in preventive visits: diet, exercise, tobacco and substance use, depression, intimate partner violence, STI risk, and then reproductive life planning and contraception and preconception counseling, of course, is huge for us. I'd be preaching to the choir, I think, if I talked a lot about potential harms of excessive substance use. So I'm going to focus more today on the intersection with reproductive health and reproductive life planning. So the data among non-pregnant women aged 18 to 44 from CDC's most recent estimates of 2015 are that more than 50% of women in the U.S. drink alcohol, and almost 20% report binge drinking, which is defined as 4 or more standard drinks in 2 to 3 hours. If nearly half of all pregnancies in this country are unintended, you can see that there's considerable risk of prenatal alcohol exposure. And in fact, the CDC data estimates that among pregnant women, about 1 in 9 report alcohol use in the last month, and close to 4% report binge drinking. Interestingly, data is wonderful stuff, and actually it shows that some of the sociodemographic characteristics of the people who reported the highest prevalence of alcohol use were pregnant are that they're white, age 35 to 44, educated, employed, and kind of equally married and unmarried. What's really concerning about all of this is that the findings really suggest that the drinking and binge drinking during pregnancy hasn't decreased over time, despite the recommendations of major public health organizations like ACOG and the Surgeon General discouraging the use of alcohol during pregnancy. Next slide, please. All right. The detrimental consequences of alcohol use during pregnancy are pretty well established. It's a really potent teratogen, and it's influenced by many factors that really aren't predictable. Genetics, micronutrients, age and parity, use of other medications, dose and timing of alcohol, etc. So really, we come down to that any dose may be harmful, and we have no way to predict which dose will be harmful. I think we've all got a pretty good picture of what fetal alcohol syndrome looks like. What we may not all really recognize is that harm really presents in a continuum, ranging from neurobehavioral disorders to full fetal alcohol syndrome. All of them are associated with permanent brain damage, rewiring of the brain, and this may actually be more prevalent than autism spectrum disorders, and often are misdiagnosed as autism spectrum disorders, which is really a shame because treatment is different. The data on the harms of other substance exposure during pregnancy is perhaps less clear, but there is evidence that even legal marijuana can have some detrimental effects. And so it's important that we address this. People need to know. Next slide. So we have a long history at Planned Parenthood of trying to assess and identify individual and pregnancy-related health risks. Historically, we've really relied on individual clinicians to determine the best approach to intervention when they identify risks. And as you know, we all have different levels of comfort and experience in doing so. So the real benefit to SBIRT to us is that it really provides an evidence-based, step-by-step, non-judgmental model for not only identifying, but also doing that brief intervention, doing that introductory address of risky use. So there have been several studies since the 1990s that have also really proven effectiveness of intervention for patients who are at risk of pregnancy and who are drinking. So two key strategies have really been identified. One is to help patients reduce, stop drinking, or use contraception effectively, or both. So we're hoping that we can do this by giving patients the information that they need to make the best choices that they can for themselves. Next slide. In 2016, PPGNHI did a primary care pilot in 5 of our health centers. And while our overall primary care pilot was not the most successful thing we've ever done, the clinicians in those health centers identified SBIRT as something that really was value added. It opened the door to conversations with patients that were impactful, and it gave them a model for having those conversations that they really found helpful. So in 2018, we were really lucky in that we were able to partner with the University of Alaska's Center for Behavioral Health Research and Services to apply for and subsequently receive a grant from the CDC to address risky alcohol and other substance use among patients of reproductive age through system-level implementation of SBIRT. So in 2019, we trained all of our health center staff in Washington, and our training really was on alcohol and substance use, prenatal exposure risks, the SBIRT model, and motivational interviewing. This year, our goal is to train all of the health center staff in Alaska, Hawaii, and Idaho, and then next year to move on to Indiana and Kentucky, where we have an alliance. This is on hold right now because of COVID-19, but hopefully we really will meet our timelines. So we started incorporating SBIRT into our preventive visits and then into our gender-affirming care visits. And we're hoping to expand to including SBIRT in our problem-focused visits like STD-related visits, birth control-related visits in the future. Next slide. So the first thing that we did was to think about where we could utilize technology to make the burden on health center staff manageable. So we actually incorporated the SBIRT screening into our mobile check-in process. So patients complete the questions themselves, either before they come into the health center, or if they haven't done it ahead of time, then we give them a tablet and some private space to do it in the health center. So they do the pre-screen questions, and then if the screen is positive, the patient completes a full audit or DAFT screen. Next slide. That then, unfortunately, our particular EHR doesn't play well with other systems, and so it isn't fully integrated between our mobile check-in and EHR. So our SBIRT scores are actually entered into the EHR either by the front desk medical receptionist if there's time, or more often by the back office medical assistant as part of the rooming flow. You can go ahead and change. Next slide. The EHR then calculates the score and actually recommends the intervention. So you can see in this one, this is somebody who screened positive and then completed the full audit, and the total score put the person at a low risk. So the recommendation is positive reinforcement in alcohol education. So that calculating whether or not the pattern of drinking confers risk. We also train our staff to look at whether or not there's any use, because somebody who's either planning a pregnancy or not necessarily planning a pregnancy but not using one of the top tier methods of contraception, then we still have to be thinking about whether or not there's risk of prenatal exposure. Next slide, please. The EHR also then basically summarizes the SBIRT model. So the clinician can, have this open as a reminder of what the different, again, step-by-step brief intervention looks like, and, shows how to document it as well. Next slide. So, as I said, we don't have behavioral health experts in most of our centers. So the workflow that we're using, again, is to have the patient self-complete the SBIRT screen and then full questionnaire if needed. Our back office support staff can help facilitate entry into the EHR, which then scores, and then it's the clinician who is actually doing the brief intervention with the patient. In our Puyallup Health Center, as part of our participation in the accountable community of health in that community, we actually have been able to locate a behavioral health counselor. And so we could easily refer people for additional assessment and treatment. In our other health centers where we don't have that luxury, we utilize the help of a referral coordinator to help make more of a warm handoff to research, what resources are available to individual patients and make a warm connection. And then we handle follow-up within our normal systems. Go on to the next slide. Some of the resources that we use really are pretty readily available. So this is an SBIRT reference sheet and pocket card that we've provided for clinicians that, gives them some pictorial tools that they can use with patients when they talk about, here's where thank you for completing this. Here's where your score puts you compared to, here's the pyramid. Here are the actual low-risk drinking limits. If they want to talk about what the actual risks are, and we do have materials that also cover this for some of the more common medications and substances that can be used. And then it actually goes through some of the steps of the brief intervention process and that's available in both English and Spanish. Next slide. We shamelessly borrow from others. So UW actually has some safer use handouts for alcohol and other substances that are very helpful when you're talking about risk reduction. You know, if you've got somebody who's identified that maybe they're using a bit more than they want to be, there's some very specific things that they can do. AHUG has a nice handout on marijuana use during pregnancy. And if you go on to the next slide, you can see that there are also materials available from www.sbirt.care that we utilize. Go on to the next slide. And then finally, we, whenever possible, try and put together brief provider guides for our clinicians so that they have kind of at their fingertips the different steps. You know, what do they need to look at in the medical record? What are the categories? What are the intervention steps? What's the plan for referral? How do they code and bill, and et cetera. Next slide, please. So we implemented across Washington in 2019, heard from our clinicians initially that this felt like it was huge. And then as people got used to it, really heard that it really wasn't a huge change in flow. Again, we have been asking our clinicians to assess and address alcohol and substance use, tobacco use, et cetera, as part of preventive care for a while. This just really gives a tool in a lot of ways. What we found thus far is that about 1 in 6 of our patients who were assigned female at birth, they screen positive for risk of substance-exposed pregnancy. So that gives us, you know, an additional framework in which to have our conversations about contraception. In the first month of doing SBIRT in Washington, we found that most of our patients screened low risk. About 15% had some risky use, where brief intervention was the appropriate intervention, and only about 1% actually needed a referral for treatment. So this is really kind of telling. Our patient population may be a little bit younger, and hopefully what that means is that we're able to intervene earlier to hopefully then prevent some of the greater consequences. Next slide. We have had some challenges. You know, using mobile check-in was a great idea, but what we found is that it is integrated well into our preventive visits, but we really use every opportunity that we have to convert problem-focused visits into preventive visits. So if somebody's coming in for an STI check, we know that about 40% of our patient population doesn't have another healthcare provider. And so we really try and turn that visit into a preventive visit so that we can do things like look at their blood pressure and talk to them about diet and exercise. And mobile check-in isn't programmed to include the SBIRT questions in those visits. And so our back office staff really do need to be a bit more involved in this. Interestingly, when we rolled out our first workflow that had some of the burden we thought taken from the back office staff, they actually objected. They felt that taking a history is their job, and so they actually wanted to be more involved in this, and so they are. One of the other challenges that we found is that marijuana is legal in Washington, and our patient population, they use it, and so our clinicians were really spending a lot of time addressing marijuana use in general. And so we really had to dial that back a little bit and give them permission to focus on those patients whose marijuana use is problematic or that causes a potential for prenatal exposure. And then time, you know, that's a big challenge for everybody. There's so much to address in a preventive visit, and this does take time. You know, with tools and training, the time can be minimized, but it's there. And so we really have had to say, you can prioritize, and a preventive visit doesn't have to be done in just one visit. And then the biggest challenge we're having right now, of course, that with COVID-19 and essential versus deferrable health services. Many of our preventive visits are on defer, so we're actually not doing as much as for screening right now as ideally we would be. I think that's the end of my slides.
Okay.
Hopefully I left us some time for questions.
Yeah, we do have some time. I just really want to thank all four of you again for taking some time out of your incredibly busy schedules to be part of this. I am seeing one question in the chat box that I think is really great from Ethan Norris. I'm just going to read out and start with this. During COVID, what have been your new challenges and how are you and your community partners using or providing telebehavioral health services? So I'd love to hear, how COVID is impacting your current processes. Lisa, you talked a little bit about that. Who would like to start?
This is Sunny from Harborview. I'm happy to address some of that. We had already been in process of launching telemedicine services that was supposed to be about a 6 to 7 month project that was condensed into about 2 weeks after the COVID-19 pandemic hit. So we have, I would say in our outpatient clinic, we typically provide we see maybe like between 300 and 310 encounters per day in our clinic. I just looked at some data today showing that we're down to about 280 encounters, and over half of those have been converted to either telephonic or telemedicine visits. So it took a little while to get there. We weren't at that point right away, but we're finally to the point where now we are able to convert a lot of those in-person visits for patients who could be at high risk or really don't need to be seen in person to a different modality so that we can continue providing services that are so essential to their ongoing care.
Great. Would anyone else on the panel like to speak to that? All right. I just asked people to type in additional questions in the chat box because I am not entirely sure how to unmute everybody. So I appreciate, oh look, I have some more actually in the different sections. So let's start with that. David Jefferson asks, is it 22% of those needing a referral or 22% of all SBIRT clients? And that was early on, so I'm assuming that was directed at one of the King County analysts.
Yes, this is Jennifer. That is 22% of people who received an SBIRT service.
Okay, great. And then Amanda Robbins asked, why in the how well of RBA data do you look at only publicly funded behavioral health treatment?
That is the information that we have access to as King County. So what we try to do is we connect people who've received the service with the services that are available to us in that publicly funded behavioral health database.
Okay, great. And then an additional question, are services available to all people regardless of immigration status, insurance, etc.? That was at the end, so I guess it could be for anyone on the panel.
At Harborview, the answer would be yes.
At Planned Parenthood, the answer is also yes. It's a little more complicated since the Title X program funding is not as available through all of our states.
Sure.
But in Washington, we still are able to offer a slide to patients who don't have a Medicaid or private insurance.
Great, thank you. Additional question from Anna Short. What agencies are available for SUD intake and treatment? Previously, some agencies were only serving existing clients. I don't know if you can speak to your own personal clinics.
So this is Jennifer from King County, and I know as people were faced with this pandemic and how they had to quickly shift things, we had some laws that needed to change to allow more telehealth and more assessments to be completed via telehealth as opposed to in person. That has really shifted, and I want to get a website. I don't have it right in front of me, so I would prefer to send a website that would help people understand what's available. I would say the Washington Recovery Helpline is always a good place to start if you're not sure what's available out there, because they would have the most up-to-date information. And if you just give me a second, I'll put it in the chat.
Or Jennifer, you could also, I'll be sending out these slides later today or tomorrow, so you
Okay.
I can include it in that email to the whole attendee list.
Excellent. I will do that.
Great. Well, so we are right at 1 o'clock, and I do want to honor everyone's time. So I just want to quickly say again, thank you for everybody, and then put in a plug for our May 27th webinar. The registration link will be in the slides. It's also here on your screen. Same time frame, Wednesday, 12 to 1 o'clock on the 4th Wednesday of the month, which will be May 27th. And then if you have any questions, please feel free to reach out to me, Amy Etzel. And then we also encourage everybody to join our mailing list to get all the good BRIE related news as well as future webinar announcements. So again, thank you all, and we'll hopefully see you next month in our next webinar. Thanks, everybody.
Thank you.
Bye.